You guys all know Dr. Weintraub, I believe.
Where's Rocco?
Home sleeping. My dog.
Did you talk to us about his fractures this morning? And maybe about his new grandbaby?
No.
Anyway, welcome, Dr. Weintraub. We'll get started.
I get very nervous in front of audiences, so you'll have to forgive me. And so I thought I would start out with just a little story, and this is a video that was produced after, how do I hit the start on this? Anybody know?
If you just keep going
One over, it'll do it. And this was a typical scene of myself or another orthopedic surgeon and their anesthesia colleagues, because Mrs. Smith just came in, and you'll hear the rest. Oh, it doesn't work. So. What do you think? Thank God Katie's here.
Hi.
Hi.
Are you the registrar of anesthesia?
Yes.
I need to book a case.
Who are you?
I'm the registrar of orthopedia.
Sure. What's the story?
There is a fracture. I need to fix it.
Okay. Tell me more.
There is a fracture. I need to fix it. There is a fracture. I need to fix it.
Can you tell me more?
The fracture is very displaced. I need to fix it.
Okay. Let's start from the basics. Where is the fracture?
The fracture is in the emergency department. I need to fix it.
That's not what I meant. Who does the fracture belong to?
The fracture belongs to a bone. The bone is a femur.
And who does the femur belong to?
The femur belongs to a 97-year-old lady from a nursing home.
Okay. Anything else you can tell me?
She is fasted. That is good.
Any comorbidities?
She is otherwise well. Except for
Except for what?
her temperature is 29 degrees
Right.
and her pH is 6.8.
Really?
And she has a condition I have not seen before.
Which condition is that?
A systole.
A systole.
A systole.
Right. And you want me to anesthetize her?
There is a fracture. I need to fix it.
Why didn't you tell me about it from the start?
I did. There is a fracture. I need to fix it.
No, not the goddamn fracture, the bit about a systole.
Because then you might refuse to anesthetize her.
Don't you think I'd have noticed a systole when the patient arrived in the anesthetic bay?
It will not take me long to fix the fracture. I'm very skilled with hammers and power drills.
She is not fit enough for a haircut, let alone an operation.
There will be minimal blood loss.
I think she has other management priorities at the moment.
Like the fracture.
Like CPR.
They have finished doing that.
Oh. They have stopped doing CPR on someone in a systole.
Yes.
That means she is dead.
There will be minimal blood loss.
You know what? You're right. There is not much blood loss when there's no friggin' cardiac output.
I need to fix the fracture.
Please go away.
You are being obstructive by refusing to do my case.
And you are making my head hurt.
There is a fracture. I need to fix it.
I need to go and punch a brick wall.
If you break your hand, I will fix it for you.
So, honestly, if there was ever a fracture that you would say there is a fracture, I need to fix it, it's a hip fracture. So I thought I would start with that because this is not working now. click
Hit your arrow key on
here
the keyboard.
on the keyboard. I'm very skilled with power tools, but not so good with computers. Okay. So hip fractures are obviously a very common occurrence. We actually see them in all age people today, not just the 97-year-old lady, but every now and then the 30-year-old guy falls off his bike and gets a fracture. But all these fractures are associated with significant mortality and morbidity. And why we fix hip fractures is because if you didn't, it would take a long time to heal. They would heal usually in poor position, and they hurt like the dickens, so people can't lay in bed with them. So even the lady with multiple medical problems who otherwise is maybe well, maybe not, you can't leave these people laying in bed in pain. Then they develop bed sores and all the other complications that go along with it. So fracture fixation is the standard and really has been for as long as there has been a way to fix these fractures. I once was asked, what does an orthopedic surgeon do? And I said, we fix broken hips. Nationally, when you look at hip fractures, within 6 months of the fracture time, there is significant mortality, morbidity, as high as 50%. Some problem will occur. They may die, but there may be something else, some significant event that can occur. Here at Good Sam, we are fortunate. We have a hip fracture service. And the hip fracture service has provided, I think, the best care, at least in the state that I know of, for these elderly people, because they often come from nursing homes. Some of them live at home in really marginal situations. They fall down, they break their hips, they come here and are greeted by, after the emergency room, are greeted by a geriatrician who is specialized in taking care of these kinds of people. And there are many things that they need, because some of them are still okay and many of them are not. There are often lots of all the gamut of dementia that can occur, but they still have a significant problem that unfortunately needs surgical care. And when we meet with families prior to the surgeries, oftentimes the families go, oh, mom's too sick or mom's too this. And then you explain to them, well, mom's going to lay in bed with her broken femur and be in pain for the next 3 to 6 months and then she'll die. Nobody wants that to happen. So fracture fixation is necessary. But since their medical problems supersede the orthopedic problems, the orthopedic surgeons are glad to step aside, allow the geriatricians to come in, take care of all the medical things, and then we come and fix the fractures. We fix lots of these here, and I thought it was higher than 134 fractures last year. I know it's been higher in the past, I think other hospitals are kind of taking the lead in trying to put together their own hip fracture services, but we see a lot, and a lot are transferred in from the other legacy hospitals on the weekends because they don't have people on call, and so they're happy to dump the hip fractures. But honestly, if your mother or your aging grandparent were taken care of by Dr. Samus, Dr. Mura, or any of those people, you would be going, thank you, because they really do an unbelievable job in taking care of these older people. Anatomy, get back to basics in case you forgot. I'm sure you know, nobody here forgot, but the femur is pretty simple, and what we do is based upon the location of these fractures. So I'll start with the easy stuff. You have the femoral head, and then you get the femoral neck, and then the greater trochanter and the lesser trochanter and the shaft. So everything is divided starting here at the femoral neck, then an intertrochanteric area, and then some combination below. Now, what's important is the blood supply in the first set of fractures I'm going to talk about is that the important thing is the blood supply to the femoral head. Because the blood supply comes from the circumflex vessels around, by the way, there is a test after this. The circumflex vessels around the femoral neck, and they go into the femoral head. These are very tiny vessels. You can never see them. They're in the capsule of the hip. So that's the main blood supply. There is some blood supply that comes from the fovea, but that's variable in all people, and you never know does it have a lot or a little. So when you get a fracture, and the first type of fracture I'm going to talk about, when you get a fracture in the femoral neck here, if the fracture moves enough, the blood supply to the femoral head will be disrupted. So the kinds of hip fractures are listed here, and we'll go on, because we're going to first talk about femoral neck fractures. Now, these have been classified, the Garden classification, and I really don't care anything about that because it doesn't really tell you very much other than someone drew some lines and said this is good. But what's important is this particular fracture, the first type, is that the fracture, it's broken, and it has been, the femoral head was like this, and when it's done, it's sort of sitting up a little straighter. It has been impacted. We call it impacted valgus femoral neck fracture. And the reason that's important, and the second one is sort of basically an undisplaced, but it's not in valgus. And what's important about that, and here's a depiction of the fracture here, is that, and there's the fracture line is right there, and you really can't see it very well. But what's important about that, remember the blood supply comes in here, and when the blood supply is just sort of pushed out of the way and the fracture is impacted, the blood supply is usually not disrupted. And sometimes you can't see them very well on x-ray, so we get MRIs to look, and this is the normal femoral neck, and you can see the fracture line here. MRIs are better than CAT scans. The emergency room's been ordering CAT scans a lot lately. I don't know why. MRI is easier to see, and you can do a very quick MRI study and figure this out. So femoral neck fractures like this one, impacted valgus femoral neck fracture, we use screws. And we use screws because it holds it in place. It's easy. You can do it through either one incision about this big or 3 tiny incisions about like this. It can be done percutaneously. It's very minimally painful, and it works very well most of the time. Biggest problem is patients have to be touchdown weight bearing or minimal weight bearing afterward, which in a lot of cases is not easy. Sometimes it's not possible. What happens late in these fractures that we don't see till sometimes as long as 2 years afterward, if the blood supply has been disrupted at the time, and you don't know till down the road, if the blood supply has been disrupted, the femoral head will die, and you get avascular necrosis, and people come in with the screws sticking into the acetabulum because the femoral head has fallen off and is dead, and then you got to go back and do a total hip. So it's usually worth the time and trouble to fix these when the fracture is exactly the right one. They don't occur that often, but when it's exactly right, it's better to do it. The more common thing we see, and this poor unfortunate person has 2 femoral neck fractures. But when you have a displaced femoral neck fracture, you have to do something else. And this one, as you can see, the one here, the right hip is markedly displaced. And fixation of that fracture with screws, with plates, everything else is not possible. The blood supply is certainly disrupted, and you have to do something about it. This fracture, and what I see when I look at this x-ray, is that this fracture has been around for a while. It's not uncommon to see people who broke their femoral neck who actually walk around on it for a little while, and they do okay, and then all of a sudden, boom, it falls off and they come to the hospital. When it started out, it probably was that other one, the impacted valgus fracture, and then they walked around and it fell off. So what we do with them, we have many options, or several options available. These unipolar prostheses, they look like this, they look like this, but they really should look like this because those prostheses are relegated to the junkyard. I have a few of them on my desk because they make good paperweights. A friend of mine uses his as an ice cracker. But they really aren't much good anymore. Unipolar prostheses are pretty much passé. And what we do now for this kind of fracture is we do what we call a bipolar prosthesis. And everybody wants to know what a bipolar prosthesis is, and it has nothing to do with your mental state. But we figure out the size of the socket, the acetabulum, and we have little things that we use to judge the size, and we pick the size. And then we get the stem in there, and the head pops into the socket piece. And what you get is a head that moves around inside here, and the big ball that moves around inside the socket, thus two planes of motion, bipolar. They are great because they are usually inherently much more stable. That's the big thing. They don't pop out as easily. However, if you work in the operating room or hear us swear, when they do pop out, they are very much more difficult to get back in. We've had a few of them that the head is actually popped out of the plastic. That's really unusual, but it does happen. But the other good thing about them is that if down the road someone were having trouble with this, you can actually pop the head off. The stem, this part here, the stem is is more of a modern day stem. And so you can actually convert that to a total hip if you had to. The problem with these bipolars is that in the best situations, they may last 10 years. And so the most significant problem that we're having with these now is that some people will come in, and in this x-ray you see the fracture, but what you may or may not be able to see from there is that there is very little joint remaining here. This lady has a broken femoral neck and an arthritic hip. Now she says, I didn't have trouble with my hip before I broke it. You have to believe them. But you know that if you go put one of these things in here with an acetabulum that is already worn, it's not going to work very long or very well. And so Barry's here right on time.
Following your example.
I know. You just can't get them every time. You know? So what's happening a lot today is that total hip replacement for femoral neck fractures is becoming more standard. And we're going to see that the statistics are really quite overwhelmingly positive for total hip replacement in older people with femoral neck fractures because they live longer. These, of course, will last someone their entire life, and they function quite a bit better. And so we always hear from the emergency room, from everybody, that the person with the one that's on my left here, it says, people say, well, they have a total hip in. That's not a total hip. The way you tell the difference is these bipolars have great big metal heads. These don't. They have an obvious socket with a ball in the socket. So that's a total hip. That's a bipolar. And so not only with arthritis, but dependent upon some other factors. And this is a lady that came into a manual with a femoral neck fracture. You can see here. And you can also see that this space, which is the joint space, she has a great joint. She has a good looking joint. Problem is that she's 53 years old. You can't fix this fracture. If you fix this fracture, it's going to fail. So what you have to do, thank you, Dr. Schenk, for giving me these x-rays. This lady had a total hip. So age makes a difference. Function makes a big difference. I mean, I think he did a total hip. There's an 88-year-old lady in the hospital yesterday who lives by herself, takes no medicines, has no problems, and she broke her femoral neck. And she has an arthritic hip, and she got a total hip yesterday, even though she's 88. Oh, by the way, I'm really big on lectures, so if you have questions, please ask as we're going along. I don't like to be the only one doing the talking. Well, sometimes I do. So the next kind of fracture we're going to talk about is the intertrochanteric fracture, called because it's somewhere between the greater trochanter and the lesser trochanter. And these are probably the most common fractures that we see. And here's another one. Now this one, the lesser trochanter is broken off, but the fracture line goes through here. And often you'll see the radiologist put little things on here like fracture because they don't think otherwise we would know what that is. And there are ways to fix these. You can use a hip screw, an interlocking nail, and the interlocking nails that we use are the trochanteric femoral nail and the gamma nail, and I'll show you a little bit about that in a second. And so the hip screw looks like this. Fracture was somewhere in here and is fixed by this. And hip screws are good. Hip screws have been used in some form for the last 60 to 80 years. And this particular kind of hip screw is more like this. They're not in the garbage can yet, but they're kind of like that kind of a cell phone. You just kind of want to be looking at something better these days. And the reason for that is because when you do a hip screw like this, you have to make a big lateral incision. You got to take the muscle down. You got to spread it all apart. You get a lot more blood loss. It is a much bigger operation. And what we have available to us now is what we call an interlocking nail. And the interlocking nails are put in from a smaller incision above the hip. You spread the muscle apart. There's very little blood loss in this proximal incision. And you can slide these nails in from the top, fixing the same kinds of fractures. And you can use a long one or you can use a short one. And they're really good for most kinds of fractures. And I brought some examples here so you can come and play with them later if you like. But basically what it is a big long nail that's put in from the top. And then we have a guide that allows us to put this up into the femoral neck and the femoral head from the outside. And so that stabilizes the upper part. What they're also great for is if the fracture is a little lower because you worry about the thing rotating, is that this is just a different kind. This is the gamma nail, has a screw-in thing. The trochanteric femoral nail, or the TFN, which is made by Synthes. This is made by Stryker. We'll give them their credit. This also, what you do is down below, if you have the thing, you're afraid the thing is going to rotate, you can put a screw that goes through the femur, through the nail, and through the femur on the other side. So everything is locked, top and bottom, and they can't twist. And that's why they work extremely well. In some fractures, you can use a little short guy. Same thing, upper screw, all goes pretty quickly. Most of us are using the longer ones these days because what we're fearful of is that these old people fall down again and they break their femur right around here. So if you put a big long nail in them and they break their femur again, which has happened, they have a big long nail, it's already in there, you don't have to worry about it. So, any questions? So, another type of fracture here again, these are some examples for you. This fracture here with a long spike, and that person gets, this is a gamma nail. How do I know it's a gamma nail? Because it's got the screw threads on it. And that's all surgeon preference. Dr. Lamprecht likes trochanteric femoral nails, and I do that because I want to be more like Dr. Lamprecht. Dr. Colorado and Dr. Schenk, they like this guy. There are other reasons, but they all work exactly the same. And this is what they look like down below with a locking screw below. Some people like me have a lot more trouble putting this screw in than other people, so I don't do that very often. Dr. Schenk does it very quickly, so he puts them in everybody. But that takes a little extra time and x-ray fiddling around to get those in. Subtrochanteric fractures. So if you remember my little diagram before, that line was going between the greater and the lesser trochanter. These are below the lesser trochanter. Okay? Now, this is what used to be done. And we used to use these too, but we don't do that anymore. I hear they're coming back. Typewriters are coming back. But anyway, this particular nail, this actually is still available if you wanted to get it. It's called a blade plate. And very difficult to put in, extremely difficult to put in. And you basically had one shot. If you didn't get it, it was over. So it's not a very forgiving device. What's more common is, again, that we use these big, long things that fix fractures. They're here. They're very, very stable when you fix them. And that's the little guy. And it really works much better. So complex fractures like this one, again, a lot of fracture lines, a lot of pieces, and the big nail holding everything together. This one, there's somebody put a wire around this fracture. Sometimes you have to make an incision and go in and grab a hold of the thing because there's too many pieces. Yes?
Yes, boss. Where does the name Gamma come from?
I don't know. No idea.
Gamma name.
No idea. No idea. Again, this one too, a complex fracture. You can see all of these fracture lines extending down. Same thing here. Lots of pieces. Lots of problems. Okay. What we are seeing more, I'm going really too fast. If you don't have any questions, I'm going to have to let you go home early today. What we are seeing more of today, and what I think we're going to have an epidemic of these things, are periprosthetic fractures. Now, they don't fall in the realm of the hip fracture, but they are certainly involved with the hip because this person has a total hip in place, fell down, and here you have this big, nice metal device down the femoral shaft, and they fall down and twist their bone just so. And what happens? The bone breaks around the prosthesis, thus the periprosthetic fracture. Periprosthetic fractures are tough. They're tough to manage because there are many, many more complicating factors when you deal with them. First of all, you got to get the bone to heal, and you got to get everything back in the right place, and that may or may not be straightforward. In this kind of situation, when we would look at this, we'd say, well, all this is intact, all this looks pretty good, it's just the tip of the stem. What should we do? Well, you're a little nervous. This is a girl in Portland, but you look at this and you say, well, gosh, that's fracture tip of the stem. You can repair it like this, which is a good way to go. And the nice part is, of course, that you didn't have to do anything to the prosthesis. But the other thing sometimes you have to do is you have to take the whole thing out and revise it. You have to put in a brand new hip, a long stem that goes almost all the way down to their knee, and you wire it all back together. When you have to do that, the problem, of course, is that you have this situation where you have decided to revise this because maybe there are more fractures around here than you can see on this x-ray, and sometimes you don't know till you're doing it. And then you have to make this new revision prosthesis fit this whole situation with the cup. Well, maybe the cup's good, maybe the cup's in good position, maybe it's not, maybe it's going to be stable, maybe it's not. And so you get into a far larger degree of difficulty and complicating factors when you decide what to do with these things. And again, we're going to see more of these because I mean, I did 3 total hips on Monday, and the combined age of the first 2 people wasn't as old as the last person. So I did 2 total hips in 40-year-olds, and these guys are going to go out and probably hurt themselves, and when they do, they'll